Thank you, Rishi, and thank you, Dr. Basak. So I'll just rush you in the next 7 minutes in the interest of time so that Dr. Fogla can follow suit after me. So much of manual DALK and much of what is important has already been covered by Rishi. So when you look at big bubble DALK, the secret lies in how you would probably achieve your big bubble without converting most of the time. So let's move on in the interest of time to uh, knowing what is the type of bubble you need to achieve. What is the type 1 and what is the type 2? The type 1 is when the Duas layer and the rest of the desmids get separated from the rest of the stroma. The type 2 is the pure desmids bearing big bubble which you would want to get. And this again is from a wonderful publication from Dr. Fogla itself, which is a good diagrammatic representation of how the bubble, when achieved correctly, is going to push your desmids into the anterior chamber. And understanding this anatomy is probably very important also in learning how to achieve a big bubble most of the times, and how you would not want to convert it into a manual DALK or into a penetrating keratoplasty rather. So the tip 1 is a preoperative case selection. Know your corneal thicknesses, know the area where the cornea is thinned out, and you will have to understand or remember to what thickness you need to partially trephine the cornea, which should be a perpendicular cut-in. So this is very important in learning when you insert your needles and in helping to achieve a good bubble, and also in dissecting out the soma when you're doing the divide and conquer removal of the stroma. Most surgeons seem to prefer general, especially when they are beginning, but I think once we are experienced, we are quite comfortable doing our surgeries under regional anesthesia as well. But remember, you do not want to have inadvertent large movements that can cause a rupture of the desmids membrane. Always remember to make your side stab entry before you do your bubble, so your chamber is deflated a little, and you have the space for the bubble to move in and push the desmids into the anterior chamber. So don't keep it too taut, otherwise this could be an impediment to your big bubble achievement as well. And as Rishi rightly pointed out, you should learn to master your manual dissection techniques as well, so that in case you're in trouble, you will be able to convert it into a manual DAC and not into a penetrating keratoplasty. Again, there is a gamut of instruments which have been described, so learn to use these instruments. There's no shortcut to learning. The learning curve of DALK is slightly longer than other, perhaps even endothelial keratoplasty DMEK procedures, but there are a good set of instruments which are available with us which help us to achieve the big bubble. I'll subsequently show you those instruments, quickly run through them after I finish the tips and the pearls. Again, when you're using an injection, air injection, remember when you use a needle, you need to orient it correctly, otherwise the tip of your needle can cause inadvertent damage and perforation, and you would land up with a perforation of the desmids even before you've started injecting. So this is by and large a total coverage of all what you have achieved. And then once the bubble is thin, most times you can perforate doing what is known as the brave slash, so you should know how you're going to go and de-roof your big bubble. Once the de-roofing is done, it is a divide and conquer technique. Again, the right instruments are essential to avoid rupture when you're blunted, when a tip can cause a rupture of your desmids membrane. You can always use the double bubble test or the small bubble test to help you understand whether you're in the right plane, and it's usually helpful when you're doing this in corneas which are not as clear as keratoconus, and you're using them for more opaque corneas as in dystrophy cases. Be careful when you're doing a quadrant removal, because perforations can occur when you're removing the residual anterior stroma, and inadvertent perforations of the periphery can result in a perforation as well. So this is again just a surgical assembly of the things where once you've achieved a big bubble DALK, you see a smooth surface, and in an IOCT you just see what is just left behind is the desmids membrane out over here. And remember, when you're putting the suture, putting your button on and suturing, you would want to wash it up, clearly remove all any viscoelastic or any fibers, debris left behind, because otherwise that is going to affect the results of your good surgery as well. So this is a quick run through of the earlier case itself. It's a 16-year-old keratoconus patient who had a Kmax of over 62, 68, and thinnest Paki of 117. You always remember when in your preoperative case selections, I generally do my DALKs for those cases when I'm not able to fit even the advanced contact lens systems in the patients. So when there's a failure of even scleral contact lenses, or the patient is non-compliant or has a significant ocular surface disease like allergy, then that's when I move these patients onto a DALK. And these patients inherently do have a higher risk of perforation even in the best of the hands. So the challenge and the expertise comes in achieving a big bubble in these kind of cases, in keratoglobus, in pellucid margins, where the ectasia is significantly much larger and more difficult to deal with and achieve a significant flattening and a good unaided visual acuity in this patient. So this is a full video clipping of the earlier points which I pointed out in this particular case. And remember, when you do a big bubble DALK, you get a smooth surface there, and careful trimming out is very important, as if you can perforate if you're not trimming out well. And then you place your donor button on, and the principles of suturing is pretty much same as you would get in any other patients. So you have these DALK instruments which help you to go insert. So you have cannulas and spatulas, and you have which help you to inject air into the stroma and help achieve your big bubble. In the interest of time, I think I will skip running my other videos, and over to you, Dr. Fogla, to take on closing the session with his final talk on conquering DMEK procedures.